It's my pleasure to now hand over to Frankie Long. He will report about the periprosthetic fractures, this time around the hip. So please, Frankie, go on.
Thanks, Norbert, for the introductions. Periprosthetic fractures around the hips are very common. In my hometown, perhaps you'll be surprised that we still use a lot of these Morse prostheses. I'm not sure. In UK, it's still being used a lot. Yeah, occasionally. Yeah, but we follow this British tradition to use this rather primitive, I would say. And a lot of these, as you can see, are not the cemented one. So what are the challenges in the periprosthetic fractures around the hip? To summarize it, it's mainly a fixation problem because we have osteoporosis, we have defects in the bone, and we also have the presence of the implant. So these three factors makes periprosthetic fractures difficult. What are the common problems? We might notice that there are malalignment of the prosthesis. Sometimes they alter the biomechanics, and it leads to a secondary revision due to loosening. And there might be stiffness or even non-unions as a complications of periprosthetic fractures. And the implant or the prosthesis itself may impair the fracture union because of the reaming that is being done. So there might be some endosteal ischemia. And all these actually will block the iron nailing or the screw fixation. So it poses a problem with the fixation as where there is an implant. Just to let you know, there are increasing numbers. It's not a very recent studies already, as we can see that this is from Mayo Clinic. Already the figures are rising, and as we all know, we are facing more and more actually periprosthetic fractures everywhere around the world. So we have to do some decision making, as in all fracture fixation, and we need to do a careful assessment of the preoperative X-rays, and it is in this particular fracture that we need to compare with previous X-rays. Normally, we don't need to get some previous X-rays, but in periprosthetic fractures is important because we would like to note, at least have some idea of the position of the prosthesis, because it may imply whether the implant is stable or not. Sometimes it is difficult to assess. And if there's fixations, standard fixation and retaining the prosthesis is usually indicated when the implant is stable and well aligned, whereas revision of the implant or prosthesis is usually indicated when the implant is loose, malaligned, or deformed. However, even if the implant is stable, if you don't have any bones for you to really fix the fracture, then of course you might have to think about revision of the implants. Preoperative planning or templating the whole thing, it's very important in all fractures, and it couldn't be more important than in fixing a periprosthetic fractures, because you must have a very good preoperative planning. If you don't, you end up with inadequate fixations proximally. You may end up with a short plate. You may end up, you don't have the required plate, or you don't have the required cables, or whatever gadgets that you have. So this is very, very important. So although we would like to do all these cases as soon as possible, nevertheless, besides optimizing the patient, one must always try to do really a checklist of what you need before fixing it. Otherwise, you have a problem. And if there's, because all these are very important, because even sometimes you don't even have rooms for the unicortical screws, because the screw tips, as we all know, of all these screws, some of these screws, they protruded for another 2 millimeters. So you need the periprosthetic screws sometimes, and that may not be readily in your set of your locking plates. So all these must be templated before the surgery. It's very important. There should be a checklist. First of all, you have to check, is the implant, is the prosthesis stable or not? Is it stable or not? And then secondly, you have to think, how are you going to reduce the fracture? Are you going to do a meatball? Usually is a very difficult case if you try to do everything closely. But whether you try to do a limited incision and try to help, I think that's a range of whether it is a meatball or a limited incision or a formal open reduction or internal fixation is a range. So probably I would say the limited incision one is usually that we go for. A pure meatball is very, very difficult in periprosthetic fractures. And the type of plates to be used, the type of plates, particularly for me, because in our locality, the patient's femur is really bold, although I would like to have a very long femoral plate. But many a times they really doesn't fit our patient. So we have to stop at somewhere. So you really have to plan the whole procedures. And the length of the plate as we discussed. The number of screws in each segment, you have to plan it. Normally, I would say you want two unicortical screw is not the same as one bicortical screws. We know that the strength of one bicortical screw is much better. So I would say 3 or 4 unicortical would be more or less similar to one bicortical screw fixation. And you need to think about cables and cerclages. Is very, very useful because you can't obtain your bicortical fixation. That's why you must have some ways to get hold of the opposite cortex. Otherwise, it just fails. It just fails. And then you have to think about whether you need the special plates or sometimes a trochanteric grip. And all these will not be readily available in your normal operating theaters. So you must plan. So the working length of the screws, I'm sure you've seen it in all your advanced courses or even in principles course. As we all know, in periprosthetic fractures, the unicortical screws, they actually don't work. They don't work. They have very flimsy fixation. And that's why we need bicortical screw fixation. And that's why this is the aim, why we always try to talk about bicortical screw fixation. But of course, the difficulty, you have a prosthesis inside here, blocking the whole thing. So you have to think, how are we going to bypass this one? It could be by means of cerclage. It could be by other gadgets as well. I'm sure we know, but just to remind you again, the Vancouver classification, very clever, depends on 3 factors. The location of the fracture, which is nothing new. In the past, the Johansson, all these uses this location of the fracture as a classification relative to the prosthesis. Stability of the prosthesis is very important. And finally, the proximal bone stock. So 3 factors in your Vancouver classifications. Just to go through it, I'm sure you all know this. Very quickly go through it. Type A, the location is in the proximal part of the femur, with a displacement of the greater or the lesser trochanter. The stability of the prosthesis is not a problem. It's not a problem, it's stable. And the proximal bone stock, because of this location, is not a big fact, is not that important as well. So you've got cases similar to this one where you can apply a trochanteric grip and cerclage wires to fix this kind of fractures. Then we go further down, is a Vancouver B, when it is just around or just distal to a well-fixed stem. This is actually quite again, I would say, a range of a fracture. It's not it's a spectrum of injuries, because it can ranges from more comminuted fractures around here, or more oblique fractures that are rather easy to fix because you can use your cerclage and things. And the other, of course, is sometimes you have a pure transverse fractures at the tip, which is, we all know, is the most difficult kind of fractures to treat, even if it's a B1 fracture. So there is a spectrum of different fractures. However, when we go to B2, it's just that the same kind of fracture location, but then the around or just distal to a loose stem. The stem is loose, the prosthesis is loose regarding, so you have a problem of fixing it. The stem won't stay in place. And the bone stock is okay. When we go to B3, then it goes slightly even one step further. That is the same location around here, and then we don't have enough bone stock. It could be a very comminuted fracture like this. It could be like this, or it could be that the previous surgery has reamed out all the bone, and you just have a very, very thin cortex, and then just next to your cement. That, in essence, is again like a B3 fracture. Should be classified as a B3 fracture because there's no way you can find any good bones in this region. That is, in effect, is like a B3 fracture. Whereas the C is well distal to a loose to a stamp like this. Very interesting. In the past, people have tried to invent many ways to treat this. Is one what we called from Professor Menon, is great surgeon, but this plate doesn't really work that well. It's what we call the Menon plate. Is stability-wise, it's actually quite nice, but it's a very non-biological fixation, as you can see. It strips everything. Just strips everything and just wraps around and kill off all the blood supply. So the stability-wise is okay, but the blood supply is a big problem. So you have a huge problem. Mechanical failure non-union is around 30%. So despite this, you have a plate, so it's not in the market anymore, I think. So there has been another shift, what we call the struck graft. The struck graft thing is like this. When you take a look at this, there is, in the past, before the advent of this locking plate, so the total joint replacement surgeons, the hip surgeons, they try to think of ways to treat it, and it goes to the other extreme. Actually, they want more stability, and how to compensate for the loss of the vascularity. They think of a way to add in something more biological. It's what we call the struck graft. Struck allograft is a piece of a fibula, and then they just use cerclage or cables to tie it around. Steve mentioned it acts like another plate, and essentially it also brings in a little bit of the biological factors. And there are just up to 1 or 2 years ago, there are still a lot of papers trying to prove that it is the structurally or biomechanically or mechanically, because those are not bio. I mean, those are just cadaveric bone. I mean, there's not even living. But mechanically speaking, this struck graft construct is the strongest. I have no doubt that it is strongest. But unfortunately, we are talking about living body. So we must take into the account of the biology. And I think that nowadays, as within this group, we like the plating a lot, and how to preserve the biology and yet to provide adequate stability. So it's a balance. You don't strip that much and you provide adequate stability. That's the key. So you have a whole lot of choices of a plate. You have to find out from your distributor or your sales representative, because you might not have that. There are many other gadgets. This is a trochanteric grip. You have your cables. You have a periprosthetic screws, though it doesn't protrude that much. You have your cerclage nuts, so that is a little bit easier without the cerclage being moved up and down along the shaft when you tighten. So these are some of the gadgets that you can use. Plate attachment, unfortunately, I don't have extensive experience in that. Because of the presence of the prosthesis is a clever way to try to get bicortical screw fixations around the prosthesis. So it makes a lot of sense, but I don't think it receives the extensive clinical use to say that it is really useful. Just some cases from Mayo is from Professor Wagner to show the application of this, because you cannot put in bigger screws, so you just have to use 3.5. But in cases like this, very, very minimal bone proximally, it's difficult to get around the prosthesis, but nevertheless, it seems to work quite nicely. Again, in this one, the whole stem actually fills up the whole thing, but still you'll be able to bypass it, and it seems to work in some of those cases. So in B1 fractures, where it's not that difficult. It's a rather long oblique fracture, so you can just reduce the fractures with cerclages and put in long plates. And then your plate attachment is always a possibility. And beware, even in B1 fractures, if you are not certain, always have your revision prosthesis standby. Otherwise, during surgery, you find out the prosthesis is loosened and you have a big problem. B2, you can have a problem with the stability of this stamp. You can have a revision femoral stamp system, and you should have your cerclage and long plates, and perhaps your strut graft if you belongs to the joint replacement school of thoughts. For the B3, because of inadequate bone stock, then of course you need a megastem or sometimes a tumor prosthesis. Some of the cases like this are very comminuted cases. I think it's also from Germany. So they've tried to reduce this together with a long stem, really long stem, and try to reconstruct the proximal shaft without the use of a tumor prosthesis. I think that's something that could be done. But nevertheless, perhaps it does not serve the purpose of early weight bearing with this construct. So the type C, I think we've done the distal femoral fractures, so I'm not going to spend a lot of time on this. So just to examine why do some of these fail. Mostly is the poor biomechanics, as we've seen the cases shown previously. Why it repeatedly fails? Usually it's due to poor biomechanics. And why nobody, when you look at the post-op, you can just tell it will fail. We all know. But why can't we tell before the surgery? Because you haven't planned it out. You haven't planned it out. You just you just ask for a 10-hole or a 12-hole plates, and then during surgery you improvise and try to make things happen. But unfortunately, it doesn't work that way. You have to plan the whole procedure. Otherwise, all these things, and then you try to blame your plate, I don't think is the correct way. And the second is a lot of disturbed vascularity of the bony fragments. And that's why a lot of these, particularly in the transverse fractures, they don't work. And that's why there are papers saying that the locking plates by itself don't work, and you need a strut graft for this. Perhaps it is so. Perhaps it is so for these pure transverse at the tip. Perhaps I would say that it may be, but for the more oblique, when you have a big, easier way to, or much easier chance to heal the fracture, then I don't think a strut is necessary. For the pure transverse, particularly at the tip where there's some cement over there, we know it is difficult, then perhaps a strut is necessary. There is another school of thought, very nice paper from the Harborview. What their school of thought is, perhaps we can get away from we have just enough stability, not to the extent of a strut graft, and yet because we can do a minimal stripping or so-called less invasive procedure and get away with healing and stability. It's balanced, so we have bony union. Perhaps this is the right way. That's why they produced this paper, trying to counteract or some of the discussions for using the strut graft. Is they use a very long spanning plate. The key is a very long plate and a minimal soft tissue dissection, just enough for the fracture reduction. And if you achieve this kind of fixation with a minimal soft tissue dissection, I think perhaps the strut graft is not necessary. But I think this, again, is not easy. It's not for every surgeon. So you have to learn the technique as well. So some of their cases like this long spanning plate. So to sum up, I think I'll just go for a one short case. 85-year-old lady, a man, diabetes, hypertension, COAD with a total hip replacement 12 years ago. Is a B3 fractures 6 months ago, and then the revision long stem done. This is the post-op X-ray. So now ambulating with a walking frame. So walking in a nursing home and felt sudden pain over the distal thigh. So what do you think has happened to him? Has he popped his ACL? Or is broken femoral stem? Or is it a fracture at the tip of the prosthesis? So make your choice. Just guessing. Okay, so most of us thinks he has fractured the tip of the prosthesis. So I hope you'll be able to see it. Yes, I think it's readily. So there is a crack noted at the tip of the prosthesis. So despite this long stem all the way and a good cementation, things still break. So it just propagates and just go further and further down. So what should be done now? It's not that displaced. Casting for 6 weeks. Plates fixation and cerclage, perhaps. A plate or a struck graft is very nice, huh? Or revision to even longer stem. Perhaps we have to go to the fusion then in that case. Then you don't have another fracture. So how should we do it? Plate fixation and cerclage, yeah, I think that makes a lot of sense. Casting for 6 weeks, yeah, that's another option. That's what we hope, wishful thinking, yeah, that's right. We also have this wishful thinking. So it was casted, so-called, by the resident, that it's not displaced, okay. But they do the job to displace it, okay. It's not a very good cast, as you can see. And once the patient moves, it's just displaced. So we have to go in, and plate fixation was done. But the surgeon find this very difficult to reduce the fracture. He wants to do a meeple with not a big wound, okay. But he cannot get this thing because of the cement over there. He cannot really reduce the fracture well. It becomes very difficult. Yeah. However, we don't have the problem still because the patients become chair-bound, and we have not seen him since then. I'm sure he's end up somewhere, yeah, better. Yeah. So in summary, I would say very important, careful preoperative assessment and planning is the key to success. You cannot just go in and get some wires, get some plates without templating the whole things. It doesn't work, okay? The location of the fracture, stability of the prosthesis, bone stock, 3 important factors. They help to determine whether you do a fracture fixation or prosthesis revision. With that, thank you very much for your attention.